Gives me a great pleasure to introduce our next speaker, Dr. Brian Berman, who's well known, I'm sure, to the audience. He's been on the advisory board of the foundation for a long time. Dr. Berman trained both at UCSF and then at the NIH, and was in Denver for a bit, University of Colorado, and is now at VCU in Richmond. Has a lot of expertise in Parkinson's and neurology, and I think this is going to be a really innovative and interesting talk, so I'm looking forward to it. I think thinking out of the box is the way you move forward, and hopefully we'll get a lot of out-of-box thinking with this next lecture. Dr. Berman?
Thank you very much for, how's that, a little better, for inviting me, Dr. Billick, to come speak here. It's a great honor. I've been with the ebraf for 9 years, I think, so it's been a while. This is actually my third time presenting at the conference, and I feel like it's interesting and different each time, and so I've really enjoyed today's conference so far. I've learned a lot myself, and it's been really a good experience, and hopefully you're all enjoying it as well. I think they put me after lunch because they were worried you might get the munchies or something, I'm not sure, but the topic of my talk was about medical marijuana for blepharospasm, and then they also said, maybe could you talk about neurostimulation as well, just sort of some alternate therapy options that may be able to treat blepharospasm. So it was actually about 5 years ago that I had a presentation that I hosted one in Denver. And it was nice. It was the 35th anniversary. Maddie Lou was there. And it was, so this is actually the 40th anniversary, which is pretty impressive, of the BEBRF. And then, 2016 feels like forever ago. Are you with me on all that? I mean, there was a few years in between, and then there was the worst year ever. I think we remember that was 2020. Lots of things to remember back, that it was a really tough year, especially with the pandemic. But during the end of last year, I switched universities. So I've been at Colorado for about 10 years, and then I moved to Richmond because I was offered to be the director of the VCU Parkinson's and Movement Disorders Center, and it was a good leadership opportunity, and so I'm now back on the East Coast. I did some training in Maryland, so it's nearby. So I'm there, so anytime you're in the area, please stop by. I'd love to see you. So today's talk, objectives. So first of all, just to give a little history and overview of the use of medical marijuana. Also review its potential of cannabinoids to treat blepharospasm. And then we're going to talk a bit about magnetic and electrical stimulation approaches for blepharospasm. So this is the cannabis plant. This is medical marijuana, not medical, this is marijuana, the cannabis plant. So as you see, it looks like, like other plants, it has leaves, a stem, and on the female flower side, there are these things called trichomes. So one thing just to say about this plant is that actually it was cultivated in prehistoric times. So it's been on Earth for a very long time. Made it to the States actually in the beginning of the US in 1611. It was in Virginia, planted, and they have evidence of the Plymouth colonies growing it in 1632. So it's been a big part of history here. There are two main types, so cannabis sativa and indica. As you can see here, there are differences in the way their leaves look. And it's just these two different types. So you might hear people say sativa or indica. It's just the two types of the cannabis plant. And it's these hairs on this female part that produce all of the cannabinoids and terpenes. And we'll get into that in just a minute here. So that's what is in it. So it actually contains about over 500 different chemical compounds. It's really a mix of all kinds of chemicals inside marijuana plants. But the most abundant part of that is called the cannabinoids. And there's thought to be about over 100 of the different compounds in it. And the one here is THC. So this is tetrahydrocannabinol, or THC. And this is the part that has the psychoactive part. So this is the part that gets people high. And it is one of the most abundant chemicals in the plant. The other cannabinoid is also known as CBD, or cannabidiol. So CBD is another abundant chemical in cannabis, about 40% of the plant actually, but it doesn't cause a high. And in fact, there's evidence that it limits the high from the neuroactive part. So it's important to keep these two things in mind as we talk about this. THC and CBD is the two prominent cannabinoids in marijuana. And then there's over a couple hundred terpenes, and these are the molecules or the chemicals that give it its aroma and scent and smell. And so that we don't generally think about them, but they make up a big part of it. So actually, it's been used in medicine for a long time. So there's evidence or literature from 1842 talking about its analgesic properties and how it may help as an anticonvulsant for seizures. In 1890, it was written down that it helped with insomnia, pain, neuralgia, also painful menstruation. And a famous neurologist in 1915 mentioned about migraine. That's probably the most satisfactory remedy at that time. So then things are going well until 1937, when this country decided to pass this Marijuana Tax Act. And they said, we're going to get rid of cannabis-containing medicines. And they got it removed from the pharmacopoeia, and so people stopped using it. I'm not sure why this became a target. Prohibition ended in 1933, and maybe they needed a new target. It's not really clear, but it was banned. And then the Marijuana Tax Act was repealed, or it was taken down in 1969, but then replaced with the Controlled Substances Act. So the bad part about this is that it became much harder to study. So come in 1970, it sort of was called a controlled substance. It wasn't widely studied, and so that's why we don't know as much as we'd like to at this point. But still, some companies persevered, and there was a few forms that became prescriptions. I don't know if you know about this, but one of them is called Marinol. Marinol is a synthetic THC component, and this has been used for nausea, pain, most widely in cancer, and also in HIV, where they could see that it could stimulate the appetite. Another brand was called Epidiolex, which I think you heard a little bit about earlier today. And this brand is just pure CBD, and it has been approved by the FDA to treat a couple of special epilepsy syndromes, Dravet and Lennox-Gastaut. And these are very specific sort of pediatric epilepsies. It's not all epilepsy that it has been shown to prove and to be helpful for. And then there's also another brand that is called Sativix, and this is about equal mix of THC and CBD. It's not in the US, it's in Europe, and it's sold, and it's been shown to be helpful in pain and in cancer. So now, fast forward after it's made a controlled substance in 1970, I come from a state that in 2012 legalized the recreational use. And so this was a few years before we had that BEBRF conference. In 2016, everyone came to Colorado thinking it was just going to be a very lit up state. And yeah, it was, but the excitement died down, and it's proven that since 2012, it didn't lead to the end of all time and civilization, as people might have thought. And in fact, what happened is since 2012, wide range of states have started to adopt laws. And this shows you that there's only 3 states remaining that have no public cannabis access program. The dark green figures here show you where there's adult recreational use. This green, the medium green, there's at least some kind of medical program. The light green, maybe a low program, or at least decriminalized. So you see Pennsylvania here is in that, where there's a medical cannabis program. So not recreational, but they do have a medical program. So really quite a number of states, pretty much almost all the states now have adopted this, though it still remains illegal under the 1970 Act. All right, so how can you get this? So I'm not pretending to be a professional in terms of what different things are out there and what they contain, but I know that you can get it in the traditional form still out there, smokable, as Cheech and Chong show you here, and I would advise against making joints that big because they're likely dangerous. But there's gummies, and so this is something interesting that came out of Colorado, is that the gummies look too much like candy, and so they had problems with children getting at it. So they started to make them looking boring, like these little squares. But you can get edibles. You can get them in oils, which you can eat or put on your skin or put into food. There's chocolate bars available. There's gum. There's these lollipops that look completely unappetizing. I mean, super skunk lollipop. I don't know who comes up with that. And cookbooks. So you could really put it into anything that you want. But there's really lots of different forms. And we'll get into why that's important later. And it's also been used for a wide variety of ailments. And I'm sure you've all seen, I mean, it's being promoted as the cure for so many things. But really painkiller, anti-inflammatory, antioxidant, anti-anxiety, antipsychotic, helps muscle spasms, does all kinds of things. And largely people have focused on CBD and THC, but some of the other cannabinoids are also thought to be helpful, and some people on smaller scale are studying them. So how safe is it? This came from a 1994 paper, which is kind of an interesting one, where researchers at NIDA, the National Institutes for Drug Abuse, and UCSF in San Francisco, they studied these various aspects of drugs that make them dangerous. So with their withdrawal, reinforcement, tolerance, dependence, intoxication, addiction potential. And they ranked these drugs here on, in terms of how, if they were less serious or more serious. And you can see here heroin like ranks up top nearly across the board in terms of its harm. Nicotine does too, especially with the dependence. Cocaine is high. Alcohol, it's hard to tell the difference actually between it and the other drugs. But then you look at caffeine and cannabis, and they're down here. So they really are considered, not much different than caffeine in terms of its withdrawal, tolerance, intoxication. Intoxication here is the higher one, so it's a little more intoxicating than caffeine. But generally thought to be a fairly safe drug. And is it caffeine or is it Botox? There's so many things on the internet, and this is just one of those. I saw that. Thought that if I was giving a talk after lunch, you might start to be dripping to a little sleepy. All right, so what kinds of adverse effects or acute effects might you expect? So everyone knows about the red eyes. This is important, right? So as we're thinking about using this for blepharospasm, you'd be interested to know what it might do to the eyes. If you already have dry eye, that's a potential. Increases appetite, which we talked about actually is sometimes useful. Can decrease salivation, so if you, that's again can cause dry eye. If it's not salivation, but decreased eye secretions. It can change heart rate and blood pressure. It can change urinary frequency. It's also, can cause you to feel good, euphoria, but guess what? It can also cause dysphoria, the opposite, and make you feel bad or anxious or panic. Just have to watch any movie with a prominent feature, you'll see lots of people panicking throughout. The time can feel slowed down, people can feel depersonalized. Some people can hallucinate at high levels. It can impair your coordination and balance, and also your memory and thinking. So quite a range of things to consider, when you're thinking about trying this, is that it can have some adverse effects. So even though I agree that it's safe relative to other drugs, it still can cause problems. So let's go into what folks are doing who have blepharospasms. Looking at this survey that just went out last year, there were 330 people who filled this out. We really appreciate all who did that. When they were asked about complementary therapies, about 55%, I think, said, no, 47% looks like, said that they had tried that. And quite a few, 56, a much smaller number, were currently taking it. And this is the list of all the different complementary therapies that were asked about. We also asked about medical marijuana. And so we had 18 folks who responded that they were currently taking it and or using it. And they had a variable effectiveness from no relief to maybe 75%. You can kind of see the ranges here. This is all 18 subjects. And this is the hard part, and this is what we see in the real world, is that all kinds of different forms were being taken. But if you look over here, almost everyone is just taking predominantly CBD rather than the THC part of it. And that might be due to availability, but it's also less likely to have that neuroactive effects. And then there were 25 people who said they had tried it and stopped it, presumably because it didn't help or didn't or had adverse effects. So endocannabinoids, these are actually our own natural chemical. So inside our brain, we're actually using something that looks just like cannabinoids. And you use this in nerve transmission, and it plays a role in memory and pain and lots of different processes. And it turns out that receptors for these endocannabinoids are in the parts of the brain that you've heard about before, like the basal ganglia, that's the striatum here, and the substantia nigra. So, they're in the right place to potentially have a benefit in dystonia. And they help regulate some of these things like muscle spasms, so muscle activity. So there's some thought that it could be helpful. And so is it helpful? Well, if you look at the evidence right now, there seems to be good evidence, not great, not excellent, just good evidence for pain relief, muscle spasticity, nausea, appetite, sleep disturbances, epilepsy. And how about for movement disorders? Well, we have some people who are like ready to go and believe in it and they might push it, but really the evidence is just not quite there yet. So I'm going to talk about just a couple of studies in Parkinson's, and you'll see why here in a minute. But if you look at Parkinson's, that's probably in the movement disorder world where we see the most research in terms of medical marijuana. And there's a mix of results here. Sometimes it's helpful, sometimes it's not. But it's important to know that when we look at evidence, there's a big difference between some of this patient survey, testimonial type of evidence versus randomized control studies where we use a placebo and the people who are given the medication don't know what you're getting. And so those are felt to be stronger evidence. But even if these were all good studies, each of them looked at a different form. So it's really hard to synthesize this information because everywhere you look, someone's doing something different, and so there's no standardization. So that makes it very hard to figure out what's helpful and what's not. The Michael J. Fox Foundation put together a survey that had 1,800 people who filled it out. And this is in Parkinson's, but as many of you probably know, that patients with Parkinson's commonly have dystonia. And if you look here, this list of 1,100 who said they had dystonia and were using cannabis, about 40% of them in this green zone showed that they were mildly better or markedly better from it. So this is a different disorder, but it's the symptom of dystonia that they're showing some benefit. And then they looked at the difference in whether they were using THC versus CBD, which one had the highest one, because we also don't know, is it THC that works? Is it CBD? Is it a combo? What is it? And if you look down here at the dystonia line where they had 964 respondents, this is the green side is the side with the high THC. So this just shows that it was those with the high THC had far better response in dystonia than those who did CBD. So And this is all suggestive, not direct studies. So I'm just, just stating that it looks like it might be helpful for dystonia, but there's some suggestion that it might be helpful if it's more THC than CBD. So let's see what's been done in dystonia. So the literature is pretty sparse when you look just at dystonia. This is one of the earliest studies I saw, 1986. They said 5 patients, 2 of them whom had Parkinson's, had improvement with CBD. But this is open label, meaning they knew what you were giving them. So those are some of the weakest evidence. Another placebo-controlled study in 2002 looked at 15 patients with dystonia. They had segmental or generalized dystonia, and they found no improvement. So how about any studies in blepharospasm? And there's really not much more in dystonia. But in blepharospasm, we found a couple studies to tell you about. So one of them in 2017, they only had 5 patients. This is a survey, but they said 3 of the 4 had improvement. And 4 others discontinued because it didn't help. So maybe 3 out of 10-ish saw some benefit. In a study in 2004, it improved pain and social life. I don't know what that means, but that was only a case report, so it's hard to know what to do with that. Good for the person. Cannabinoids of dystonia, it really, we don't know. This is a paper that just came out last year. It really just reviewed all the evidence, and it says, looks like it helps in some cases, but we don't have good evidence to know that if it's going to be helpful in dystonia. But then we have the ebraf, who's stepping up and trying to pursue and see if we get some benefit. So in 2019, funded a study with Dr. Silkis in UCSF, and I guess we're going to be hearing about her results soon. It was announced earlier today. So excited to hear about that. They did use CBD, so it'll be interesting to see what the results were, because CBD would be better tolerated and safer. So we'll await those rules. So in case you're wondering, what do I think? What do I recommend? I think it's safe to try. I mean, I do come from Colorado, so take that into consideration. But the direction, if we were to advise a patient, we'd say, start low and go slow, right? There's no reason to start with the 3 brownies or the Cheech and Chong joint. Just start low. Probably start with the CBD predominant first, just because we know that's going to be safer and better tolerated, or low concentrations of THC, because that might actually be needed for it to have a better effect. Be aware of those adverse effects I talked about. Be aware of drug-drug interactions. If you're on particular medications, you can talk to your doctor. And then, tolerance and dependence are possible, but it's like it is with caffeine. And then the other important part is that form of ingestion, it matters. And so I'll just give you an example. So here is the blood levels after someone smokes marijuana. And you can see this is in minutes, like it reaches a peak at 10 minutes, right? So that's a big peak, happens fast. If you eat it, then we're talking here, these are by half-hour increments, so it's a much longer, lower, flatter curve, right? So how you ingest it is going to change its effects as well. All right, this is what you might look like when your Botox doesn't take at the same time. All right, so deep brain stimulation. So this is an example here where you see an electrode that we surgically place into the brain. It goes down into the deep structures like the thalamus or the basal ganglia, and we send out electricity that is, because it's connected to a battery. So this is just a battery that's stimulating these structures inside the brain, and they have an effect to disrupt this abnormal circuit in the brain that we talked about before. And in dystonia, overall dystonia, so this isn't just blepharospasm, it's thought that it leads to a reduction on average of about 50%. So it's pretty good. But remember, averages are averages, and so half the people were better than that, and half the people were worse than that. And so it's good, but there's half the people who are getting less than 50% benefit from an invasive surgical procedure. There's some interesting thing about how long it takes for DBS to work in dystonia, and it can have some adverse effects. And the battery runs out, you got to change the battery, you can have infections, things like that. So it'd be nice to have a better option. So deep brain stimulation in blepharospasm, as was asked earlier by someone here, it's hard to find it in isolated blepharospasm. And I've done a lot of research in dystonia and blepharospasm, and in about half the time that people have blepharospasm, they have spread to their lower face. And so often, just the eye and the lower face, we sometimes label as mage. But really, this is very often just blepharospasm patients. So it's hard to, but people use these terms differently sometimes, and so we don't know if it has cervical in it, but generally speaking, mage syndrome is predominantly blepharospasm, but bad enough that it involves the lower face too. And after all these studies, where you can see like a lot of the studies are just single people, but it adds up. They did like 80, 90 some. And when you analyze all of those together, you find that it does seem to help dystonia in mage syndrome, and reduces it like a little bit more than half. So this is a score of severity from 21 to 8.6, and also help reduce disability. So I think there's good evidence that it could help. But again, as I mentioned before, that's a surgical procedure. That's not for everybody. It would be nice to have some other option. So is there a way to stimulate the brain without going inside the brain and sticking an electrode? So this is transcranial magnetic stimulation, example here. So transcranial means it goes from outside the cranium into the craniums. And this is generated by electricity that's run in circles. When you generate electricity in circles, it creates a magnetic field that goes right into the brain, and in the brain it starts to make a circle of electric fields. So really, you're doing electrical stimulation in the brain, but you're doing it through a magnetic process. And the FDA has actually allowed this device to be used now for all kinds of disorders: major depression, migraine, OCD, smoking, bipolar depression, and anxiety. And just so you know, when the FDA approves a device, it's not the same as a vaccine or a new drug. That this is just, the device is approved because it's not going to kill people. It doesn't say that it's effective. So just keep that in mind. So how about in blepharospasm? So my prior mentor, Dr. Hallett, who's the head of the medical board for the BEBRF, they did a study about 15 years ago where they looked at TMS, transcranial magnetic stimulation, and they stimulated this part of the brain they thought like it was involved in blinking, called the anterior cingulate cortex. Gave a 15-minute session, and it improved the symptoms. But that was only 6 patients. So Gogo Krantz went back to Europe. They didn't do a follow-up study, but another group published where they did this at 6 weeks. So you saw how when we do Botox, Botox works reasonably well for blepharospasm for many people. There's lots of limitations. The effect probably maximum at 6 weeks. So maybe we can give the TMS right at 6 weeks and see if we can get it to last longer. So they did do that, but they found that it only lasted a little bit longer, 2 weeks, and then it sort of the effect goes away. So that's one of the problems with this TMS. And one of the criticisms is like, well, it seems to work. You're changing the brain dynamics, but it just doesn't last. It just is, that's why DBS works, because it's continuing to do its work the whole time. And then this paper just came out just a couple of months ago, another paper looking at blepharospasm patients using transcranial magnetic stimulation. This time they did 20-minute sessions for 20 days in 35 people, so much more. And they found it was helpful in those blepharospasm patients who had anxiety and depression. So this is interesting, right? So now they did the study of blepharospasm, but only those who had anxiety and depression were the ones that got better, and not the other ones. But then you look at their effectiveness, it got only slightly better. They were already getting great efficacy. And I'm most encouraged by this part, that it lasted 17 weeks as opposed to 13 weeks. So some hint that it might be helpful. It might help us prolong the effect of Botox, which would be great, I'm sure, for many of you who are having to go through the discomfort. So something to think about. But this is where I like to think about more than magnetic stimulation is electrical stimulation. So we mentioned the magnetic is, inducing an electric current in the brain, just doing it through magnetic waves. Well, you can also just stick a battery to some electrodes and stick that to the scalp, and then just send the current in directly. So this is called electrical stimulation, and it's called transcranial electrical stimulation, or TES. And there are lots of things, units out there for sale right now. You can go out there and buy this. This one I think is for migraine. They have it for depression. So the convenient part about this is that you don't have to go to the NIH and have someone use this big magnetic stimulation. You can just buy it yourself and strap it on your head. I'm not telling you to do that. I'm just saying you could. Just saying you could. You know, there's still much to be worked out. Like, what do we stimulate? How long? What's the best way to do it, right? So that all needs to be worked out. But this is called electrical stimulation. And if you do stick a battery, like this Energizer 9-volt battery, that's called direct current. So this is just 9 volts being transmitted the whole time. You can also do like the wall, just not the same voltage, but the wall kind of gives you an alternating current. So that's another process. So here's a report in 2017. They looked at direct current stimulation for BEP, and I'll just call your attention to the fact this is a case report. So then they showed some benefit. Then there's another case report a few years later, person who had cervical dystonia and blepharospasm, case report, they thought it worked. This is just the worst kind of evidence, but at least it's encouraging, you know. So I took that as encouragement, and so several years back, I got some money from my department in Colorado and from a grateful patient, Mary Russet Kern and Jerome Kern, and they provided funding that I could check and to do an alternating current stimulation in dystonia. And this is another advantage of electrical stimulation compared to magnetic stimulation, is that you can put on this cap and stimulate the brain, and we can put you in a brain scanner, an MRI scanner, and see what it's doing. Because if we take a step back, people are like, are you telling me that you can put a 9-volt battery on your scalp and this is going to do anything? And so there's a lot of skeptics out there. So one of the things I wanted to do was to try to say, like, okay, I'm going to measure that it can do something to the brain. So what we did is create a alternating current type of setup where we did the brain stimulation over the motor cortex of the brain. And we used a frequency that is thought to prevent the brain cells in the motor region from stimulating, from activating. So hopefully it would be inhibiting the excess motor activity in dystonia. And put them in the scanner, let them rest, scan them, then stimulate them and scan them, and then rest and scan them. And then also I did a study where we treated them for 20 minutes a day for 5 days to see if it had any effect on their symptoms. But we also used TMS to measure what we call inhibition in the brain to see if it actually changed the brain inhibition. So this is a picture of a subject's brain. And this is we can use a scanner to measure blood flow. And so this is measuring blood flow. And if it's high blood flow, it's red. And if it's less, it's towards the blue, cooler colors. And then this is before stimulation and during stimulation. So this is kind of exciting that there was a change in the cerebellum's activity, blood flow, from stimulating up here on the top of the head. Cerebellum's in the back. That's kind of cool. So that makes me think I'm doing something. We also looked at, this is just essentially looking at the brain to see if it's, if there's areas that are in harmony, harmonizing or in sync. And this found that where we were stimulating, you could see brain activity that was in sync. So sounds promising. So then I sold that to the BEBRF, and they funded me in 2018 to say, why don't we do the same study that you started with cervical dystonia patients in blepharospasm? And so got that was in November 2018, and started to recruit some patients in 2019, and then you saw that worst year ever occurred, and there's some other problems that happened in all this. So in the end, we wrapped up, and I moved. So I did get 8 blepharospasm patients, 9 controls, and we also had that 11 cervical dystonia patients. And I'm not trying to keep you in suspense. I just don't have the results right now. I hope to share them with you in the near future. So we're just wrapped up the study to enrollment, and I'll let you know next time. So thank you all. It's so great to be here. It's an honor to see all the patients. The ebraf has been great to me, and it's been just wonderful to work with everyone for so long now. Dystonia Coalition and the Dystonia Medical Research Foundation have also helped support me throughout my career. And then I have to say thank you to my family and my son, whom you met.
So we'll do the Q&A now for Dr. Berman, so if anyone has any questions, just pass them up. And while we're waiting, I have a question. Have you actually, two questions. One, have you prescribed CBD for any dystonias? And when you do, this isn't really regulated, so how do you know that the patient's getting what the label says is supposed to be in the bottle?
Yeah, no, that's a good question. So things changed a little bit, Colorado to Virginia, but so in Colorado, because it was just more accessible, so they could go buy that. And it is true, you go to a pot dispensary and it has these percentages and it has things listed, but we don't really know if those are accurate or not. And actually, we ran a study in Parkinson's disease, and we had to go to a special lab that specially tested every week exactly the concentration in order to do a research study in this, because I showed you how a lot of the studies have all kinds of different forms. Well, unless it's tightly regulated, who knows what people are getting? And so it's really hard to assess that. So I generally just stick with the guidelines. I can't personally, I haven't personally given out medical marijuana cards just because I get federal funding and it's still illegal federally, so I'm not involved with that. I just give the guidelines. I say start with something that says it's all CBD, but we don't know. I mean, it could say CBD only, and it could have THC in it, and so I don't think there's a good way to do it. That's part of the problem. Yeah, so what percentage of THC would you recommend with CBD oil? So I don't know if there's a CBD oil that's available that has THC in it. If you were going to use it, I would just start with the lowest and then work your way up. I will say I'm a little bit biased that I do think that THC is an important component in terms of some of the benefits that we're seeing. And so I think it's good to have some. It's just, I'd rather not gain a lot of weight or sort of start to see things that aren't there. So, it's sort of this balance of trying to work at the smallest amount. And, the dispensaries, I don't know if they call themselves pharmacists or what they call themselves, but, you can try to talk to them and see if you can find something that is on the lowest end that's available, probably where I would start. Someone asked about the difference between CBD and CBG, and I don't know. I mean, I don't know a lot about the difference. I think the marijuana plant itself contains so much more THC and CBD that that's really where a lot of the focus has been. But there's probably evidence, it's probably that CBG can do some of the same, has a similar mechanism of action. So I imagine that it might have some benefit as well. I just don't know, and I don't think there's been proper studies done with it. Someone asked about cognitive behavioral therapy in treating anxiety and stress. And I did give a talk on anxiety and social anxiety to the DRMF not too long ago. And I think, this is, I'm definitely in support of it, at the bottom line. I think the CBD, cognitive behavioral therapy, not to be confused with CBD, has some of the best evidence in terms of those. I think it's important. Sometimes it's not all that is needed, and so you have to incorporate that with some medications, but I do think CBT, cognitive behavioral therapy, is good. When taking CBD pills, is it important to wait till after a meal? Does it make you sleepy? Yeah, it's good questions. The sleepiness, there's, if you saw the adverse effects, and this has been my experience in talking with patients. Some people get revved up, some people get sleepy. There's this idea that like indica, the sativa, the two brands that people swear by, sativa wakes you up and the indica is a calmer. It's like, but just as many people say the opposite. And so it really seems that it's independent, whether or not you might feel one or the other. I don't know too much about taking it with the meal. When people take it in oil form, I will tell you, this is like Epidiolex, comes in oil, which you're probably not on. But the ingesting a lot of oil is not great for you and not great for the liver. So, you know, usually the amounts that you're taking are pretty small. To take an amount that we found was going to really have an impact, you have to actually take a lot of oil. So, so I don't know if it matters too much. Probably if you take it with food, you'd absorb it the same, but I don't know.